please start in 3, 2, 1. Please start, sir. We are live.
Okay, sir. Namaste and good evening, everyone. I welcome you all for today's webinar on latest breakthrough in oncology treatment update 2024. With immense pleasure, I would like to invite Dr. Varun Goyal. He is a senior consultant medical oncology at Rajiv Gandhi Cancer Institute, Delhi, for the welcome and introductory note. It's over to you, sir.
So, good evening, everyone. First of all, thank you for joining today. Today, we are going to discuss about what are the latest breakthrough in oncology treatment updates. And our today topic is mainly regarding lung cancer. So we all know that lung cancer remains one of the leading cause of the cancer-related mortality, and it's like it is a most common cause of cancer, mainly in men after head and neck cancer, and in both sexes also. It is one of the top most common cancer, incidence-wise and mortality-wise. So very recent advances in treatment have significantly improved survival outcome. We may discuss about the recent TKI targeted agents and immunotherapy combinations of all the agents versus various sequences. So as I may share here that today only I've seen one patient of metaxone inhibitor, although patient was localized, but we have started CTRT, but patient couldn't tolerate, have gone to aspiration pneumonitis, have been in the ICU since last maybe 2-3 weeks, now stable. And in view of metaxone inhibition metaxone mutation, we are going to prescribe capmatinib. So we have different options in immunotherapy, target therapy, and there are many recent trials which have catered various combination of these agents based on the PD-L1 value and based on the various mutations which we can check via easily available tests like NGS nowadays. So this CME session will explore these advancements, focusing on their clinical application, emerging challenges, and future directions. So by staying abreast of these innovations, we oncologists can optimize outcome of the lung cancer patient across the disease spectrum. So topic like flow of the today meeting will be like, first we will discuss overview of lung cancer, then what main molecular mechanism and molecular pathways are there for the pathophysiology of the lung cancer and which we can target. And then we will discuss about the EGFR mutation at large and what all options we have with real world evidence of different TKI which we have available and where we can use that in advanced setting and as well as in the adjuvant setting. So with this, thank you once again, and we will start with the first session. First session is, as I told, it is regarding overview of lung cancer, and this talk will be given by Dr. Ashish Gupta. He is Chief of Medical Oncology, Unique Hospital, New Delhi, Dwarka. And over to you, Dr. Ashish.
Okay. Thank you so much, Dr. Varun, for inviting me for this conference, and thanks so much to the organizers as well. Let me share my screen and see if you can see what I'm saying here. Stop the share. Let's see how this works. All right. Can everyone see my screen?
Yes, sir.
Okay, perfect. All right. So as Dr. Varun said, we are really lucky now in lung cancer that there have been a lot of advancements because of the personalized treatment. Kind of goes with all cancers, but I think lung cancer was one of the cancers in which this kind of movement really started off. As far as immunotherapy, targeted therapy, now antibody drug conjugates, and further therapies. So in the next couple of minutes, I'll just try to give an overview of lung cancer. As Dr. Varun just mentioned, lung cancer has a big burden in India. These are statistics from about 4 or 5 years ago, which shows that in both sexes, lung cancer is about the 4th most common cause of new cases, and similarly for cancer deaths. However, in males, it's the second most common cause of cancer. We know that worldwide, the most common cause of cancer death is lung cancer. So certainly is a big burden of disease. We all see this as medical oncologists in our clinic on a daily kind of basis. It's one of the top cancers in India, and in the world as well. So certainly a very important topic. As far as staging goes, the optimal staging is required now to determine the best treatment options in early lung cancer. As I was just explaining to a patient the other day, that before, say maybe even 5 or 10 years ago, when we used to talk to patients about treatment, it would be okay, it's not spread. Let's operate first, and then we'll give you some chemotherapy, right? And so kind of it was one size fits all approach. But now with the more specificity of treatments and the recognition that not all lung cancer is the same, not all stage 1 lung cancer, not all stage 2 or stage 3, especially lung cancer, is the same, that has really widened the treatments and really helped us to improve these outcomes by a lot. So kind of specifically when we talk about staging 7th versus 8th edition, the major change as far as treatment goes that affects us on a daily basis is that before these T2s it was kind of a broader definition, and the T3s was also a lot broader. Now in the 8th edition of the AJCC staging, now hopefully coming soon, the 9th edition, we have really grouped our T2As and made them even earlier. So in other words, we're calling our stage 2s of more than 4 centimeters versus more than 5 centimeters before. Our T3s are more than 5 centimeters versus from more than 7 centimeters. And that has really kind of included a lot more patients and a lot of the newer therapies that we're now giving them, because the recognition that size, as we'll see in a few slides, really determines the propensity of the cancer to spread to the nodes. And so this is kind of an important distinction that when we look at some of the trials that have been done that have improved outcomes in early lung cancer, it kind of makes a big difference. As far as staging goes, we have a lot of tools at our disposal to stage these patients: bronchoscopy, CT of the chest with contrast, PET CT scan, EBUS, and endoscopic ultrasound, mediastinoscopy if required, and MRI of the brain as well. So which one of these tests do patients need? CCT is usually a pretty good test. However, we know now that it overall has a lower sensitivity and lower specificity than a PET scan. And so in most of our patients now, it is recommended, especially for stage 3 non-small cell lung cancer patients, that we do add a PET CT, because there is a propensity that we'll find an occult N2 that we see on a PET scan, but we're not able to see that on a CT scan. And what really determines these occult N2 nodes is, number one, is the size of the tumor. And so if we have, if we're talking about the central tumors, the size is more than 3 centimeters, the chance of an occult N2 met is around 25% at a size of more than 3 centimeters. Versus it's about the same for peripherally located tumors. As far as SUV, when we look at PET scans, we're always kind of fixated on the number of 4 usually for a lot of our patients, especially in India where we see a lot of TB, and it's kind of hard to distinguish, is this infective, is this inflammatory, or is this malignant? More than 4 SUV indicates that yes, a patient has a much higher propensity of having an occult N2 met, or around 10.5% versus very low. So central tumor, size of the tumor, and higher SUV on PET, this is a risk factor for an occult N2 node. But I think now most of us have, we've been getting PETs routinely on our patients for all stage 3 patients, and also for many of our stage 2 patients, because we don't want to risk missing anything that is not visible on a CT scan. When we talk about mediastinal staging, EBUS is the standard of care. If we're not able to sample the nodes with EBUS, we do end up getting a mediastinoscopy. The reason for EBUS or endoscopic ultrasound, if there's other nodes that we're concerned about, is that the treatment now significantly changes. As I said before, the treatment was not so different depending on which nodes were involved, etc., as long as it was kind of localized and or somewhat resectable. But now, because that really changes things, most of us will end up getting an EBUS on the majority of our patients, if not all patients. There is an algorithm to follow. For example, if we get a PET scan and we do not see any suspicion of mediastinal lymph nodes, then the question is, do you still have to do a mediastin or a EBUS or not? If they're clinically N0 and there is a low probability based on size, SUV, as we just said, and the location of the tumor is central versus peripheral, then an option is to straight away go for surgery. So it's a higher probability based on size, central location of the tumor, etc. Then it is recommended that we do end up always getting an EBUS. And if the nodes are negative, then we go for surgery. If the nodes are positive, then we go for multimodality treatment, as we'll discuss. If the PET scan does show that these nodes are positive, and if they're bulky nodes, then we do have an option to forego EBUS. But if they're non-bulky, then you end up wanting to get an EBUS. And so basically, I think what this kind of algorithm shows, and if we talk about more of clinical practice, especially where cost is not a consideration or is not as big of a consideration, is that we want to get an EBUS because that changes things. Sometimes there is false positives, there's also false negatives as well. So, kind of get an EBUS if at all possible. This is, kind of about the non-invasive and invasive staging modalities. PET scan, as we see, is a lot more sensitive than just a plain CT scan. Then we said EBUS is very, very sensitive. There are some nodes that we cannot get, and if you're suspecting that there's disease there and that there is not disease in the other mediastinal nodes, then we can get an endoscopic ultrasound. And best, obviously, surgery or VETs, which is obviously most accurate in these settings. Evolution of therapy. So lung cancer is, as we said, is not all just one disease. Non-small cell versus small cell based on just plain histology. Even the non-small cells they behave differently if it's adeno versus squamous, especially when it relates to the molecular make of the tissue and the suspicion of a mutation or not. And then we have other markers like PD-L1 and TMB that we have really been using now to decide on therapies for a lot of our patients. Advances. So with all of this research knowledge, some of which we'll discuss briefly in a minute, we have been making advances, right? So when patients think about cancer, they think about death, but in lung cancer, many of our patients are living for many, many, many years. And if we look at this graph, paper from NEJM, we can see that, this even is like 10 years old, but basically the incidence has been decreasing here, but so has the survival has also been improving. And so lung cancer specific survival improved from 26% to 35% in 2014. This is, again, old data, about 10 years old. Since then, we've had, obviously great advances in this setting. So we are doing better. What have been the advances specifically? I think one of the things, there's obviously a lot of drugs on this slide, but one of the things that I really like to point out to our patients is that as early as even 5, 6, 7 years ago, immunotherapy was not being routinely offered to our patients, even in the stage 4 setting. It was essentially not even have invented then. So, by the time that most of us have started training or are in practice, these drugs were not available yet. So this is, again, very new, and now it's like we try to give it to almost every single patient that is out there in the stage 4 setting, and now increasingly in the stage 2 and stage 3 setting, even before surgery. The molecular makeup, targeted therapies were in place as early as 2011, but really 2018 is when we saw osimertinib, our amazing EGFR drug that really improved outcomes a whole lot for these patients, especially in the Asian population where we see a lot of these mutations being positive. And since then, we've had a plethora of drugs, ALK, ROS, etc., that have come about, patients living for many, many years. And so as we can see, before this slide was not looking as rosy, now it's looking as rosy. And so when we tell our patients that, yes, we have been making improvements in cancer, it's not just 1 year survival for all patients stage 4. I think this really proves that, yes, these drugs are coming, and we have patients that are living for much, much longer than they would have been before when we were using a one-size-fits-all approach. This slide is a little bit old. 7 molecular alterations were approved as far as FDA-approved therapies for lung cancer. We have more now. With this NCCN slide, we also have HER2, we also have KRAS G12C. EGFR is also so separate based on, exon 20 versus 19 or 21. So, molecular makeup really determines a lot. And so I think we, as medical oncologists, keep telling our patients, should you have surgery? Should you have radiation? Are you going to live for a long time or not? Let's first get the testing. Let's start treatment. Let's see how you respond, and then we will know how, because the biology is different, even within each of these subgroups. So I think that's a positive thing for our patients. Now, coming to some of the treatment guidelines, again, this is also a little bit of an older paradigm. I just wanted to show this because this is back in 2017, ish era, where for our early stage lung cancer patients, the treatment was if they're resectable versus unresectable. If they're resectable, you want to go in and operate first, and then you give them chemo based on the stage. And if they're unresectable, then you want to give them concurrent chemo radiation. And so that was the treatment for these patients. And at the time of surgery, depending on what you find, it's an R0 versus an R1 versus an R2 resection, you would go ahead and re-resect versus give chemo RT, as is kind of standard principles for most of the other tumor types as well in that setting. And for R0, if it's a small tumor, then you don't give as much chemo. If it's high risk or it's a bigger tumor, or if nodes are involved, then you certainly would give chemo. But overall, when we think about lung cancer, the issue was that you give surgery, you give some chemo radiation, but 30 to 50% of patients would remain cancer-free depending on the stage. But you have a huge percentage of recurrence, more in the 70s if it's stage 3, more in the 20-30% range if it's stage 1 or 2. Local or distant. So overall, a significant gap as far as the outcomes and improvements that we need to make in lung cancer. We're very familiar with the adjuvant chemotherapy for lung cancer based on the latest meta-analysis, where they show that there was a 5% benefit of giving chemotherapy, 5% a numerical benefit of giving chemotherapy versus not, in patients with stage 1B to 3 lung cancers. And the definition of stage 1B has, as I said in the beginning, has changed a little bit. More than 4 centimeters is reclassified now as stage 2, but for stage 1B, we will still give, which is that 3 centimeter range, if they are high risk, have other high risk features. We will certainly still give them 3 months of chemotherapy. So the latest meta-analysis based on cisplatin-based combinations, 4 of them showed that overall survival did improve, hazard ratio 0.89, 5% absolute overall survival benefit. So we will give chemo to our patients because that is a big difference. Now, especially more relevant now, question was, do you give induction versus do you give adjuvant? There was really not a big difference based on retrospective trials and meta-analyses of those trials, that there was, the same, about 5% benefit either way. You give it before, you give it after, was not a big difference. And so most patients, our tendency was to operate first and then to give adjuvant chemotherapy. But this has now certainly changed. So you can see the graphs, it's about the same hazard ratios, adjuvant versus neoadjuvant, about the same. So, kind of this had been the paradigm for many, many years. Only recently, in the last 2-3 years, has this changed. So, so now we talk about our EGFR patients, right? How do we improve our outcomes of lung cancer? A couple of big trials over the last couple of years, only since last 3-4 years, have really improved outcomes a lot. And for now, we're talking about our early stage patients. One was the ADAURA trial, right? Huge improvement. This was for EGFR mutated patients, in which they showed that after surgery, these patients, if they got osimertinib, great drug, for 3 years, did very, very well, right? So hazard ratio was 0.17, then 0.20 when they reanalyzed the data, and showed that their DFS was 27 months versus it was not reached in this EGFR mutated population, which we see very commonly in India and Southeast Asia. So huge improvement in DFS. These patients were able to live much, and now we have OS benefit as well, which was a concern when the trial initially came out. So now this is for EGFR mutated patients. What about for your PD-L1 high patients, which is another subgroup? For stage 2 to 3 lung cancer, this is now approved. If PD-L1 is more than 1%, we said, okay, we've been giving immunotherapy in the metastatic setting. what about the earlier stage setting? And they saw that this does certainly make a difference in these patients. So it is approved for stage 2 to 3A lung cancer patients, PD-L1 more than 1%. So those were the kind of the two major trials. One, as far as the adjuvant setting, one is your ADAURA trial, the other one is your Empower 10 trial. Now I'm not a radiation oncologist, but just briefly talking about radiation. Radiation has also improved over the years. What we've done as far as radiation is that now IMRT, even IGRT is used, where they've been reducing the dose to the heart with lower rates of grade 3 pneumonitis. And so as we are being more specific as far as our chemotherapy regimens and our understanding of treatment, same thing to some extent has happened with radiation oncology as well. We do use SBRT, so I think something that some of the primary care doctors need to know is that SBRT, focused radiation, unresectable patients, or they cannot tolerate surgery for some reason, or they're inoperable, I shouldn't say unresectable, get SBRT in the early stage setting. And it works very well. We also use this especially for oligometastatic disease, which is very different than IMRT. So again, this was the paradigm before. Unresectable patients, we use radiation along with chemotherapy. Now, coming to a landmark trial for our stage 3 non-small cell lung cancer patient specific trial. We've all heard of this trial. Great outcomes here because again, after resection or after chemoradiation for stage 3 patients, unresectable, outcomes were still not great. So we were looking for newer things to do. Immunotherapy was out there, and they found that regardless of PD-L1 status, this therapy, immunotherapy, was approved for these patients and made an improvement, around 10% numerical benefit as far as overall survival. And so this big benefit, and so we certainly give durvalumab to these patients if they have not progressed after treatment with chemoradiation. All right. So now, what are the emerging treatment paradigms in non-small cell lung cancer, especially, and as we said, it's all about targeted therapies and immunotherapies. What are we specifically looking at? Now, talking briefly about the metastatic setting, osimertinib based on the FLORA trial and now the LAURA trial, where we're combining osimertinib with chemotherapy, showed a big benefit over simply giving a first generation EGFR TKI hazard ratio 0.46, right, which we don't see in oncology a lot of the time. ALEX trial, on the other hand, ALK positive patients, a little bit lower, percentage, maybe around 5-7% of our patients, we see this specific mutation in, but these patients live for many, many years. This is the ALEX trial. We know lorlatinib, the PFS, OS is even longer, specifically not reached. So we have patients living for 5, 7, 8 years. We've seen patients living on a tablet a day, with minimal side effects, do very, very well than your typical lung cancer that does not have a targetable mutation. Around 50% of our patients will have a mutation. So certainly we should get this testing, should get the full panel if at all possible. So certainly should be done. All right. Other emerging targets, we now all have drugs for all of these, including HER2, MET, RET, NTRK, HER2. We have Enhertu now used in the second line setting currently. So as far as survival outcomes, what really specifically has improved? Historically, typically when we think about non-small cell lung cancer with chemotherapy, even with maintenance therapy, a year or less than a year was what we were telling our patients, and what we were expecting as well. But now with EGFR, ALK, RET, etc., you can see a lot of these non-reached words all over the slide, and patients living for 3, 4, 5, 7 years, something unimaginable as early as 5 years ago. With a lot of these patients. And so certainly worth getting the testing and getting the drugs for the patient. Now, immune checkpoint inhibitors is really using body's own immune system to fight cancer, is really blocking the signal that by which these cancer cells are able to hide from the immune system, enabling the immune system to fight cancer. And we've seen that many patients have very long-lasting results even after stopping immunotherapy, or even after having maybe a horrible side effect, which forces us to stop the drug in 1 or 2 doses, and they live for many, many years, you know, even technically, or I guess not technically, but so-called cured in the stage 4 setting, which is why we always like to give these drugs. Immune checkpoint inhibitors, as with every other cancer almost now, lung cancer specifically, many, many, many approvals. I'm not going to really go through a lot of these, but in the metastatic setting, first approved in the second line, then the first line, first in the PD-L1 high patients, then in the PD-L1 more than 1% now in all PD-L1 patients, because that's not a perfect biomarker. We will give these drugs mostly in combination with chemo. If the PD-L1 is very high, then even without chemo, it works. A couple of different flavors, atezo, nivo, ipi-nivo, pembro, etc. But mostly all do similar things in the metastatic setting as well. And now, as I said, we're kind of bringing this into the unresectable and the resectable adjuvant, because we always want to do better to our patients and improve the cure rates as much as possibly can. So similarly, we've seen that with immune checkpoint inhibitors, it's not just a year. Patients are living for, on an average, 1.5 to 2 years. And there's a percentage, if they have PD-L1 more than 50%, a lot more than that even. All right, so now one other paradigm, which you know, even during my training really changed during the middle of my training. One was the ADAURA trial, the other one was the Empower 10 trial, as we talked about. And the third really big trial at that time was Checkmate 816. And your Pembro trial, and now your perioperative Nivo trial. So a couple of these different trials, which have, when we see something working in the metastatic setting, then you want to bring it into the adjuvant setting, and then you want to bring it forward into the neoadjuvant setting. So we've seen with breast cancer, we're also seeing a lot with lung cancer now, that if in the in vivo environment, microenvironment where you have a lot of tumor tissue, you give these immune checkpoint inhibitors, they work a lot better. We've seen PCR improves, overall survival, DFS improves, and we're also seeing a sign for overall survival improvement in some of these trials as well. The first one of these trials was Checkmate 816, where we saw that in stage 2 to 3A lung cancer patients, you give 3 cycles of Nivo perioperative along with chemotherapy, versus chemotherapy made a huge, you know, almost a 12 times difference as far as PCR rates. DFS was improved, and there was a huge difference across all PD-L1 levels, especially more than 50%. And so this has now become one of our standards of care. Keynote 671 was the other trial, which had recently read out, which showed that Pembro, along with chemotherapy, this was now perioperative. They also included your N2 patients, made a big difference as far as your DFS and your PCR, giving Pembro up to 4 cycles before, along with chemo, and then continuing for the completion of the entire year. And so now we have been using this in a lot of our patients, especially those in which you know, our kind of our T3N1s, our T4s, are, you know, some of our single station N2s. But multi-station N2s has still been kind of an issue, and you know, and that's kind of, we know now that multidisciplinary tumor boards play a big role, and perioperative nivolumab has also shown promising results in this area. What's new? ADCs have now also been approved with Enhertu in a non-small cell lung cancer. So I think really this perioperative therapy, looking at new targets, especially KRAS, a lot of those are still not discovered or proven yet, and also looking at newer EGFR targets is kind of what we are moving towards. And so really the takeaway, that management landscape is really fast changing. Yes, we like to say this about all cancer, but really specifically about non-small cell lung cancer, certainly newer therapies have a huge potential to improve survival. Overall survival is improved across various subtypes. Oral pills over infusions has really helped. And it's crucial to discuss these cases in multidisciplinary tumor boards, because they certainly play a big role, and it's not one size fits all anymore. Right? Thanks so much for listening. Any questions? Happy to take them.
Thank you, Dr. Ashish Gupta, sir. For the next talk, I would like to invite Dr. Kiran Kumar Mata, sir. He is a consultant medical oncology at American Oncology Institute, Aligarh. He will give his talk on molecular testing and its implication in lung cancer. It's over to you, sir.
Thank you, Nishant sir. Yeah. Am I audible?
Yes, sir. You are audible.
Yeah. Can you speak us? Good evening, all my colleagues and Nishant. Hello.
Yes, sir.
My voice is actually audible to me. Something.
Sir, can you
सर आपने 2 डिवाइस से ज्वाइन किया है.
Please, can you close that? I'm not able to.
Sir, you are audible. Can you log out from one device?
Yeah,
You
I'm
need
trying
to
to,
join
but
only
not-
one device.
No, I'm trying to, but not able to. Can you try, Sanjay?
Sorry sir.
No, I'm not able to log off one of them. So can you do it for me?
Sir, now unmute yourself, sir.
So please unmute yourself. Dr. Kiran, sir.
Kiran sir, please unmute yourself, sir.
Sir, please unmute yourself.
Are you able? There was an issue here. Yeah.
Hello, Kiran sir. Hello, Kiran sir.
Am I audible?
Yes, sir, perfectly audible, clearly.
Yeah. Can you please put the slide? Maybe then we'll see whether there's any issue.
Yes, sir, we will present.
Nishant, can you please display the slide? No, one minute. Nishant, am I audible? Hello.
Yes, sir, audible.
Yeah, can I start?
Yes, sir.
Good evening, all my colleagues. Today, I'm here to discuss about the molecular biomarker testing in lung cancer. I'm Dr. Kiran from AOI Aligarh. Next slide, please. So the agenda will be like I'll discuss about the lung cancer prevalence in India, and then followed by the biomarkers testing in non-squamous cell carcinoma lung, followed by the evaluation of the biomarker test in the past and the present days, and the key takeaways. So the burden of the lung cancer in India, as per the Globocon 2020, is that it's the fourth most common cancer when all the sexes, like including both men and women, across overall the population. But when coming to the males, it is the second most common cancer after the head and neck cancer. So, coming to the incidence and mortality, lung cancer is again next one. So, coming to the lung cancer, again, it is the fourth most common cancer in incidence, and death rate also is the coming to the mortality rate, it is the fourth most common malignancy causing high mortality with a 5-year prevalence of 5.86. Next slide, please. So, coming to the molecular markers, 50% of the patients with advanced non-squamous cell NSCLC, which are nothing but the adenocarcinomas, have a driver mutation. So almost 50% people are having, according to the FDA, that at least we have an FDA approved agent for many of them. So the most common of all the EGFR sensitizing agent, which is 17%, which caters to that. And we know that for EGFR, we have the targeted therapy like crizotinib, alectinib, ceritinib, and lorlatinib. And coming to the next most common is the KRAS mutations, which cater about 25% of all the biomolecular mutations. In the KRAS again, the KRAS it's a point mutation which is located at the codon 12. So G12C is caters to 13% of all the KRAS mutations. So and KRAS mutations have a bad prognosis. Very important to know about the KRAS mutations. And the other will be like ALK positivity, which is seen about 7% of all the NSCLCs. And a few of the people also will have EGFR, which is a rare EGFR exon 20 insertion mutation. Though it is rare when compared to EGFR sensitizing, it has a again bad prognosis. So the rest will be the MET positivity, HER2 positive, ROS1, BRAF, RET, and NTRK, PIK3CA, and MEK1. So all these, it's important to know that because every of these molecular, we have a target for all of them, and we can target therapy, and we can increase oral survival of the patients. Next slide, please. So the importance of the previous slide. So what's the importance of the biomarker testing is the oral survival. Here we can see in the slide, the blue line is for the targeted therapy. So wherever the biomarker is available, so we have a target therapy. So targeted therapy versus conventional chemotherapy, the oral survival has significantly increased with 18.6 months in the people with target therapy availability, and those with no target therapy availability, the oral survival is only 11.4 months. So this is the significance of biomarker testing. Next slide, please. So guidelines recommend a routine biomarker testing to guide the treatment patients in advanced NSCLC. So as we commonly routinely do that, EGFR and all cross we do for almost all the patients, and even all the guidelines suggest for ASCO, NCCN, ESMO, and CAP. All the guidelines suggest for all testing for all these three mutations. And recently, some few more testing also has been recommended. So PDL1 again is almost all the guidelines suggest for PDL1 testing. Apart from that, the BRAF mutations have come into picture nowadays because of the importance, and also the prognosis is very bad with those patients. So BRAF importance is also very important. The downstream signaling pathway in the RAS pathway is again BRAF is very important, followed by the other uncommon things like MET exon, RET gene fusions, and NTRK gene fusions, and KRAS. KRAS with a bad prognostic thing is very important to do that. So here we can see that NCCN and CAP guidelines recommend to test KRAS mutations for all of the people because KRAS mutation indicates poor prognosis, and also patients with KRAS mutation are unlikely to benefit from other molecular therapy. So it's a very bad prognostic marker. So all these NSCLC patients, but it's recommended to do KRAS mutations in all of adenocarcinomas. Next slide, please. So methods of tissue testing in NSCLC, we have different types of testing. Either we have a DNA sequencing or RNA sequencing panel. So DNA is by NGS and PCR. So what are the tests being detected here are insertions, point mutation, and deletions. So these, especially the insertion point mutations are very common with EGFR, KRAS mutation, BRAF mutation, HER2 mutation, and MET mutation. And single gene or full gene both can be done with NGS panel. Similarly, RNA sequencing panel is more useful with fusion abnormalities, especially that ALK, ROS1, RET, and NTRK. Where the fusion abnormalities are more, the RNA sequencing comes into picture. Similarly, we also have a role of IHC and FISH, especially with ALK. IHC is very important, and ROS1 also we have we can confirm, we can do by IHC. When IHC positive, we can go with a FISH. So ROS1 also IHC and FISH come into picture. So and also IHC has a role in detecting PDL1. So these are the common methods of testing the different types of biomarkers. Next slide, please. So just let us see the evolution of biomarker testing in NSCLC in the past and present days. So as we know, most of our specimens will be either a biopsy or a slide, which is a cytology sample. Nowadays, we also have the liquid biopsies. So the biopsy sample can be either a resected sample or a excision. And coming to cytology, either it can be a FNAC as fine needle aspiration or an exfoliator, depending upon the location of the tumor. Either it can be urine, acidic fluid, or pleural fluid. And we can also have cerebrospinal if it is a CNS tumor. And liquid biopsies we collect from either blood or a cystic fluid. So after the collection of samples, the different types of processing are, we can have a FFPE block, or if come to cytology, either it can be a cell block or a normal slide. and we have the liquid in the liquid biopsies. So once the block is made, we have the histology and cytology. So depending upon and similarly for liquid biopsies and IHC, we have PDL1, especially PDL1 and DI deficient mismatched pages. We have the IHC test. So these are the basic tests. Once block is made, once histology is reported, then we also have advanced tests like extracting a DNA from the block. We can extract the RNA from a DNA and a protein from the RNA. So these are all advanced tests. So DNA assessment can be done by either PCR, cancer gene panels, MSI, or whole genome sequencing, or whole exome sequencing, RNA by RT-qPCR, gene expression panels, and RNA sequencing. Come to the protein proteomics. So these are all the advanced tests presently having a major role in especially detecting the lung cancers, especially in adenocarcinoma. Next slide. So how to establish the diagnosis? We usually do a biopsy and we establish the diagnosis. So either it can be squamous or non-squamous, then followed by biomarker testing. Usually both the primary tumor as well as the metastatic site has equal weightage. So whichever is easily accessible or amenable, we can get a biopsy from them. There is no harm in both will have concordance, so there will not be any change in the biomarker. And other important thing is when coming to metastatic lesion, if it is a bone biopsy, it is suboptimal because of decalcification and degradation of DNA. Otherwise, any other biopsy is equally equivalent to the primary tumor except a bone biopsy. Coming to liquid biopsies, selfie DNA are another option. Like this can help us to prevent the it's a very non-invasive technique and very much useful. So coming to the what are the biomarkers to be tested? So these are the biomarkers to be tested in all the non-squamous NSCLC like adenocarcinomas, especially EGFR, ALK and ROS1, BRAF V600E, NTRK, red gene mutations, and MET exon 14 skipping mutations. So all these is a must and recommended in all this non-squamous cell adenocarcinoma present day. So how to test is by NGS testing. So NGS testing will give us detect multiple genes at a time and also in the least amount of time possible. So coming to the squamous, is there any role of testing biomarkers in squamous cell carcinoma? Yes, there is definitely a role, especially when the patient is young and patient is light or never smoker, or if the biopsy specimen is a mixed histology like adenosquamous. So there is definitely a role for the same markers in a squamous cell carcinoma also. And as we know, we all do routinely we are doing PD-L1 expression in all the NSCLC. So PD-L1 is another important marker. Irrespective of adeno as well as squamous, PD-L1 is required. So completion of testing within 10 to 4 working days is important because the biopsy, the sample will be degraded. So TAT time should be 2 weeks or 10 working days or 2 weeks. Next slide. So as I already spoke about the liquid biopsies, there is the importance of circulating tumor DNA testing has been it has a very large potential to be applied across all the stages of NSCLC. Not only in the advanced stages, even in the early stages, we can detect the ctDNA. We can predict the prognosis. We can predict the progression and relapse. So this ctDNA helps in diagnosis as well as treatment selection. Treatment selection in the sense that to select the primary TKI targeted therapy as well as a second line therapy once there is a progression in the first line targeted therapy. And monitoring prognosis, it also helps in monitoring the prognosis, ctDNA prognosis. Once the treatment is started, to see the prognosis and response of the treatment depending upon the level of ctDNA and also the progression or relapse at the earliest stage. Before imaging catches the relapse, even ctDNA can pick up in the early stage. So similarly, ctDNA testing overcomes some major challenges associated with tissue testing. Like we can do multiple times. We can do it from it's non-invasive and it's multiple serial biopsies can be monitored for a serial study, like to study the tumor response and all. Similarly, ctDNA is not a direct reflector of the tumor, but it reflects about the overall the genomic information about the tumor rather than the histology. So ctDNA testing may never replace the tissue biopsy. Tissue biopsy is always important. It is never replaced, but could have a complementary role to support the treatment selection and especially in the response of the treatment too. Next slide. Next slide. So ctDNA is used to detect MRD, minimal residual disease after a surgery in a resectable NSCLC. So this slide tells us the importance of the ctDNA even in the early cancers, early lung cancers. So ctDNA testing could identify patients at risk of relapse even if the patient is completely cured even after resection. So presence of MRD can be used to is used to predict the disease recurrence, as we all know. So MRD can be identified using the traditional diagnostic methods. It can't be done. So the ctDNA is the only method we can identify the residual tumor or the recurrence of the tumor at earliest. So we have the tracer RX study in here. 24 early stage NSCLC patients followed longitudinally after resection. The ctDNA profiling was done. Here, the study has shown that 93% of the patients with disease recurrence were MRD positive, which was done by ctDNA profiling. Similarly, 90% of the patients without recurrence were MRD negative. So the study has finally, the impression is that ctDNA profiling was able to confirm MRD negativity and detect MRD in the patients who relapsed before their disease was picked up by the standard imaging. Next slide, please. Next slide. So, as a ctDNA, we all know that ctDNA is a liquid biopsy. So, what are the pros and cons of both tumor tissue and liquid biopsy? So, sample acquisition is much easier with the liquid biopsies because just drawing a blood of 10 ml or so. Tumor tissue is an invasive technique, but repeat sampling is a problem with the biopsy, the tumor tissue. But liquid biopsy we can do any number of times because it's a minimally invasive procedure. Coming to the biology, correlation with histology and cellular phenotyping is possible only with tumor tissue, but whereas the ctDNA is not correlated to histology, but it reflects the genomic landscape. Coming to sensitivity of the assay required, the lower tumor cell content of at least 1 to 10% is enough, and this can be detected in tumor tissue. But in the liquid biopsy, we need a very sensitive test because ctDNA reflects only about less than 1% of the cell-free DNA. So very sensitive techniques are required and expertise is required for liquid biopsy assessment. Coming to evidence of clinical utility, there is a substantial evidence for the tumor tissue to decide about the primary treatment as well as targeted therapy even after failure of the primary treatment advanced carcinoma. But in liquid biopsy, the evidence is not that strong as of now, but the studies are going on as of now. But I think in the future, the increasing it will help us in giving a lot of evidence. Next slide. So there are different types of techniques, biomarkers. So what are the different techniques of identifying them? One is NGS. So NGS here helps us to identify multiple genes in a single test. So multiple genes involved in NSCLC, as we all know right now. So either a single gene panel or multiple genes, how to do. So if it is a single gene panel, it will take time. You have to individually analyze each and every test. Once it is negative, then go for the other. So EGFR, all individually we have to do all of them. But if it is NGS, all the tests will be given in a single time. Of course, it will take 2 weeks time. But once the results are out, we can have the complete picture of the biomarkers of the specific tumor in a specific person. So depending upon the positivity, we have different targeted therapies. When it is negative, we have a non-targeted chemotherapy. Next slide, please. That will tell us better about that. So what are the advantages of NGS? So it has a number of advantages over single gene test, as the number of clinically actionable biomarkers has increased. We have seen so many biomarkers already found out in the lung carcinoma. The ability to evaluate all known molecular alterations in a single test has given NGS a major advantage. See here, we have a table here. So if one or few molecular markers are required, always the weightage is to the single test, doing a single test. But if many markers are required, so by the histology, so always going for NGS has a higher weightage when compared to the single test. And also the higher NGS costs are associated with NGS are a higher cost. So this is one factor to be considered, and longer turnaround time. So NGS will take a minimum of usually for our centers is taking 2 weeks. So these are the little bit some of the advantages. So we have to keep in mind in all these factors. So when we are requesting for either a single reflex or NGS panel. So pros using NGS for single test were that it detects a broad range of molecular alterations in a single test, single sample, and may identify new markers too, which are even yet to come. We may also identify those tests by NGS, which may have a role in the future next coming decade. The cons are that it's a complex work, requires higher expertise personnel, and advancement in the field of NGS are evolving rapidly. So both the patient as well as the clinical community require continuous educational support to know about the newer developments. Next slide, please. Next slide, next. These and all I'm going to explain in the further coming slides. Next slide, please. One more slide. So these I'm going to elaborate. This is the data which I have shown there. So coming to the EGFR mutation in lung adenocarcinoma, the most important mutation biomarker testing in lung carcinoma, and most of the adenocarcinomas have EGFR positivity, at least 30%. Next slide, please. So what are the sample types used for EGFR mutation testing? Either it can be formalin fixed FFPE sections. We have the fresh frozen samples, alkaline fixed specimens. All of them can be used for PCR based assays. Similarly, cytology samples are also suitable. Even a slide can be used for EGFR testing. But whenever we are using a cell, better to do a cell block so that we can have a better assessment. So cell blocks are preferred over smears, but still we can do with the slide too. And discordances between EGFR mutation when compared to the primary and metastatic site are rare. So either we can do from the primary site, if not possible, or if it is a deeper site, we can get it from a metastatic site too, unless it is a bone biopsy. Next slide, please. So EGFR mutation test in early lung cancer. So until 5 years back, we were doing only for the advanced adenocarcinomas. We are doing the metastatic adenocarcinomas. We are doing EGFR testing. So presently, there is a role for the early cancer too. Next slide, please. Next slide. So here, NCCN guidelines are suggesting that consider adding molecular testing of EGFR mutation to be performed on a diagnostic biopsy or a post-surgical resection sample to ensure the EGFR mutation results are available for adjuvant therapy. So there is a role for adjuvant therapy. We can take a decision depending upon the EGFR positivity, especially NCCN has specifically recommended for stage 1B to 3A, 1B to 3A. So definitely there is a role for EGFR testing even in the early cancers. Next slide. So what is the test to be performed on EGFR, either PCS or PCR or NGS? So definitely, many of the studies have shown that 48.6% of EGFR exon 20 insertion mutations identified by the NGS are missed by PCR. So NGS is a comprehensive test which can identify almost all the tests. Similarly, out of the 17 most common EGFR exon 20 insertion mutation variants, only 4 can be identified by PCR. The rest of the 13 were skipped. So definitely NGS is as upper hand over PCR unless the cost is a factor. So detecting all the types of mutations involved with EGFR. Next slide. So after the NGFR, the important one which we are already doing were ALK rearrangements. Next slide. So many of the studies have shown that here ALK can be done by IHC with a very good sensitivity of 93 to 100%, and even specificity is also very high. So compared to fish, ALK for IHC is enough. So fish is not mandatory. And also for fish, there is a false positivity rate of 0.1%, and IHC is very less. It's not expensive, and as of now, we are practicing with IHC for at least for the ALK. Next slide. And after the ALK, the third most important, we are practicing the ROS1 rearrangements. Next slide, please. So this is the flowchart, how we go for the routine test. Usually we do EGFR, ROS and ALK, many of the patients, especially in adenocarcinoma or non-squamous and non-smokers in squamous histology. So we do EGFR either by PCR and NGS. We already told that NGS has an upper hand. So followed by ALK. I already told that fish and IHC both can be done, but we can IHC is more than enough. Next is ROS. So coming to the ROS, again IHC and fish both are available. So the thing is, if you do with IHC, it's positive, confirm with fish. If you do with fish initially, again, some guidelines are saying we can confirm with fish, IHC also. But the best thing is, so detection of ROS1 by IHC is best because it's a it's a cheaper test. IHC is a little less costly. So once it is confirmed by IHC, then we can, if it is positive in IHC, then we can go for fish. So if it's positive, then we can treat with targeted ROS1 target therapies. Next slide, please. What happened? Okay. The next one is the BRAF mutations. So again, we know that in the downstream from the epithelial growth factor receptor, this is the downstream signaling pathway. After EGFR, we have the RAS, and the signals go to RAF and the MEC, ERK, and then finally to the cell, which helps in the cell survival and proliferation. So coming to the KRAS mutations, they are mutually exclusive with EGFR and ALK. So these are the many of the newer studies, especially NCCN has recommended for doing the KRAS mutations, because KRAS is positive, EGFR and ALK, they are mutually excluded. One thing, and the other thing is 30% of the lung adenocarcinomas are showing KRAS positivity. So what are the mutation KRAS? It's usually a mutation either in the codon 12 or 13, most commonly the codon 13. So which is basically a change in the nucleotide from G to 12C. The variant found is G to 12C. So exon, at least 30% of the exon mutation, KRAS mutations belong to G12C variant, and most of them will have a poor prognosis. So this is the importance of KRAS identification. You have to at least that they are having 30% of lung adenocarcinomas having, and all of them are having poor prognosis and mutually exclusive to EGFR and ALK. So nowadays the new data is showing that to do KRAS mutations in all the adenocarcinomas. So what is the method of detection? So we usually a single gene KRAS G12V testing is not currently recommended at all. It should be performed as a part of multi-gene NGS panel. And the targets that be available for KRAS mutations are sotorasib is currently approved. So, and also trials are going for adagrasib. Phase 2 and phase 3 trials are going on. Next slide. So now the BRAF mutation, which is another important, the same pathway is involved here also, EGFR, RAS, and we have the BRAF mutations. And most of the BRAF mutations, as we already know that many of the mutations, at least more than 50% of BRAF mutations cater to the V600E mutation of BRAF. So other mutations like V600K, G466V, and G469A are less prevalent. They occur about only 17% of the BRAF mutation. And coming to the most common BRAF mutation, it is usually more prevalent in the smokers. The overall prevalence is about 1 to 5% of all the NSCLC patients of this BRAF mutation. So again, NGS is generally used for multi-gene panel detecting of this BRAF mutation. Of course, we have IHC and PCR also. The best thing is NGS. Coming to the targeted therapy, there's an important thing is that most of the time BRAF is involved with resistance in MEK. So most of the time we combine BRAF targeted therapies along with MEK inhibitors. So MEK inhibitor can block any possible resistance pathway and result in improved clinical outcome. So currently approved therapies for V600E BRAF mutation are dabrafenib plus trametinib. And of course, there are some resistance pathways too that we are going to know in the future. Next slide. The other uncommon, very important receptor mutations were the c-MET receptor tyrosine kinase, and especially this is an exon 14 skip mutation. Here we can see the DNA with exons and introns, exon 13, 14, 15. Similarly, we have the introns 13, 14. From the DNA, the mRNA, and from the mRNA, the protein. So pre-mRNA, mRNA, and from the mRNA, the protein comes. So here, the mutation here is that a skip mutation where the exon 14 is deleted. So from DNA to pre-mRNA, this gets skipped, sliced. So the final protein doesn't have the exon 14. So finally, the protein doesn't show the green one here. This is exon 14 protein derivative, but here it is not there. So how do this causes cancer is that eperocyte growth factor usually is a growth factor for this. So when there is a growth factor, there is a downstream pathway activation. So when it is to be shut down, the ubiquitin ligase is a protein which degrades that, and automatically the cell survival stops. But when there is a pathology or when there is a skip mutation, the ubiquitin ligase will never bound to that MET ligase, and this will have a continuous proliferation. The downstream signals are continuous, giving the rise to the cancer. So it is 3 to 4% of non-squamous NSCL's prevalence is that 3 to 4%. It is also seen in some most of the sarcomatoid cancers, 20 to 30%. And these will be detected by DNA NGS and RNA NGS, but the sensitivity is better with RNA NGS. Next slide. So what are the tests to detect the MET exon 14 skips are that? One is IHC. IHC and FISH are not recommended. FISH, though it has some value, but best is NGS. Even again, DNA has potential detecting many mutations, but most sensitive is RNA. So RNA based NGS is better for this testing. Next slide. So the other uncommon mutation again is RET receptor tyrosine activity with RET fusions in NSCLC. So usually the RET gene is very important gene, which is especially required for the neural development and also genitourinary tract development. So here the pathology in the cancer is that this is a RET gene and we have the KAF5B exon 15 gene. So this is a translocation, so leading to a abnormal protein, which gives to rise of chimeric cytosolic proteins with constitutive activity for the RET kinase domain, which will have uninhibited proliferation of the cell leading to cancer. So the prevalence is 1 to 2% of the non-squamous cell carcinoma will have this RET mutation, but it's most commonly seen in papillary thyroid carcinoma, especially it's catered to 10 to 20%, especially in the familial type. And majority of the RET fusions can be detected by DNA NGS, but again the sensitivity is good with RNA NGS. So such studies RNA-based NGS test for RET detection. Again, coming to the methods of testing for RET fusion detection, IHC and FISH, not much role for them. And again, coming to the DNA, already discussed, DNA NGS is have a role, but best is RNA NGS because the sensitivity is high with RNA NGS. So test is RNA NGS. Next slide, please. Next slide. The other more fusion protein again after RET is NTRK fusion. So again here also is very uncommon. Very less than 2% of the mutations are related to NTRK. Again, RNA NGS is more sensitive with this. And coming to reflex NGS versus IHC, though IHC has a role, but definitely NGS has a better say. So recommended is NGS. This is another uncommon. Next slide, please. So advantage, all of these tests are recommended. IHC, FISH and NGS all have a role, but advantages like rapidity is seen with both IHC and FISH. NGS will take some time. But the thing is, advantages are like low cost. It's widely available in almost all the centers. It takes transcribed and translated events only. The advantages with NGS are potential for multiplex testing, less depletion of the tissue, even a small amount of tissue we can do the test. Fusion partner and position are defined. And again, RNA NGS is better as a high sensitivity compared to the DNA. Disadvantages are IHC, the depletion of tissue, and fusion partner and position is unknown in this. We just know whether it is positive or not. Less well validated currently. So again, when coming to the FISH, the results are a little bit difficult to interpret. And again, fusion partner is unknown. NGS is better, but the only advantages are cost and longer wait time, at least about 2 weeks. So choice of assay will depend upon the institution, the resources, and the clinical context. Reflexing to NGS versus IHC is reasonable for NSCLC due to the low prevalence of, because this is not that common, less than 1% to 2%. So we can skip this. Okay, next slide. So other important mutation, as we have seen that HER2 in breast and stomach, we have again seen in lung 2, which are HER2 mutations. ERBP2 is present in 3 to 5% of adenocarcinomas. Especially most of them are exon 20 in-frame insertions, and almost all the HER2 mutations are mutually exclusive with other mutations. So mostly seen in the never smokers, non-smokers, and the outcome, the overall survival is worst when the HER2 positivity is detected. And so HER2 mutation and amplification we have to detect. This is also recommended because the prognosis is very bad with these patients. And the NGS DNA panel is a better test to identify HER2 mutation and amplification.
Sir, sorry to interrupt you. Time is running short.
Yeah,
Kindly
almost a few more slides only. I'm almost done.
Okay, sir.
So this is the paradigm of molecular biomarker positivity. We have different types of molecular positivities. One is EGFR, where we have the osimertinib preferred, and we have also other TKs like erlotinib, afatinib. And coming to the exon 20 insertions, we have mobocertinib and amivantanib. The other uncommon things, we have afatinib and again osimertinib can be tried there. Coming to the ALK positivity, we have alectinib and brigatinib. ROS1, we are already using crizotinib and entrectinib. BRAF is already told dabrafenib and trametinib. And NTRK entrectinib is there, RET. Sulpiritinib is there, and metexone, we have capmatinib. So all these are used as first line, and once there is a progression, we also have options of second line therapies. When there is no option for immunotherapy, there we can have always an option of chemotherapy. Next slide, next slide. So the PDL expression in NSCLC, next slide please. So we have different antibody clones. So depending upon anticlone, we have a different scoring system. We have 4 types of antibodies and 4 types of this thing, and we have 4 immune check inhibitors. So again, depending on diagnostic type, we identify and we can treat them according to. So PD-L1 has a major role nowadays. Next slide, please. So these are different scoring systems are adopted depending on the antibody use. We have SP263, 22C3, and 28.8, and SP142. Next slide, please. So biomarkers for immunotherapy, yes, it's a sole current biomarker is the PD-L1 as of now, which is widely available and also exploited. The only imperfection about that was even PD-L1 negative tumors can still respond, though mostly when added to the chemotherapy, maybe it's because of synergistic effect. But currently, the sole biomarker, the best for immunotherapy is the PD-L1. And other biomarkers found were like tumor mutational burden. They were not currently used because there are certain lapses with that. Even MSI high and MMR were not relatively, they are not relevant in lung cancer. And LAG3, the lymphocyte activation gene 3 is also not, is being studied. Let's see what will happen in the future. Next slide. So conclusion is that biomarker testing in NSLC has evolved from single gene to multiplex testing to NGS. So multidisciplinary meetings help in better understanding in the, as well as in the clinicians. Sample should contain adequate tumor content, at least 10%. And ideal that time turnaround time should be 2 weeks or 10 working days. High throughput platform such as NGS can be used to screen several genes at a time, rather than getting delayed with a single test every time. One more slide. Next slide. So these are the oncogenic targets and testing methodologies. I already discussed EGFR, BRCA, KRAS, PCR, and NGS is better. This has already been discussed. This slide. Next slide, please. Okay, thank you.
Thank you, Dr. Kiran sir, for wonderful talk. For the next session, I would like to invite Dr. Dharmishta Basu sir. He is a medical oncology at Rajiv Gandhi Cancer Institute, Delhi. He will give his talk on advanced EGRFM and SCLC, evidence-based review of targeted therapy. It's over to you, sir.
Can I please have my slides displayed?
Yes, ma'am.
So will the organizers be displaying my slides or should I share it myself?
Ma'am,
Okay.
you can also.
No, this is visible. Thank you. Can we start the slideshow?
Yes.
Good evening to respected audience, and thank you for this platform to present regarding the review of targeted therapies in metastatic NSCLC EGFR mutant subset. Here, I have been asked to discuss the evolution of osimertinib, the standard of care in the first line for all the EGFR mutant metastatic NSCLC. How did osimertinib stand up to be where it is in this front line? Next slide, please. Globally, lung cancer, as we know, epidemiologically, it is one of a grave cause of concern because it was the second most common diagnosed cancer in the males, third most in the females back per Globocan 2020. And in India too, we are not lagging much behind, though there are other malignancies that take precedence. Over here too, lung cancer is one of the important cause of public health concerns. Non-small cell lung cancer is the most common form of lung cancer, and that is the subset that we are concentrating on in today's discussion. Next slide. So, as we know, it is of common knowledge that the earlier we diagnose any form of cancer, the better it is for the patient. To come to figures for this particular form of metastatic NSCLCs, we see that hardly 1.2% of our cancers are actually detected at stage 1, whereas 65.9% of these patients are unfortunate enough to be detected in the metastatic stage. Considering the 5-year OSs, the OS begins from a very good 92% at 5 years for the people who are diagnosed at stage 1A1, whereas we know how dismal the prognosis is for the people who are the patients who are diagnosed at stage 4. So the importance of generating awareness regarding symptoms and diagnosing the cancer early, and also generating more and more treatment options for the metastatic line is of prime importance today. Next. Biomarker-driven lung cancers are extremely important because, as we know by common knowledge, that targeting a biomarker than giving conventional chemotherapy gives a significantly much better overall response rates, and that translates into a much more superior PFS and an OS. We have two types of biomarkers, as the theory goes. Predictive biomarkers are indicative of therapeutic efficacy, and there is an important association of this biomarker between administration of a particular treatment that would impact the patient's clinical outcome. Prognostic biomarkers are indicative of the patient's survival, independent of whatever treatment has been received by the patients. The distribution of biomarkers between the Western population and the Indian population is a little different. In the Western population, KRAS forms a very important mutation among the lung cancers, whereas EGFR takes a backseat. But in the Asian population, approximately 30 to 40% of the patients can be expected to harbor an EGFR mutation in the metastatic stage. Hence, the importance of frontline treatment in EGFR mutant NSCLCs. Next slide, please. The testing methodology for various mutations in adenocarcinoma are to be especially well popularized among the practicing clinical oncologists, so that we can guide our patients the right way. EGFR, when tested on a standalone format, when it is tested on tissues, it is tested with the use of quantitative PCR. When it is tested on a blood sample, we can use ddPCR. ALK is tested by IHC and FISH. ROS, when tested, it needs to be tested by IHC and reconfirmed by FISH, as this has already been discussed. And PDL1, as we know, TPS is tested by IHC on tissue samples. Next slide, please. EGFR driver mutations are most commonly concerned in the kinase domain. The tyrosine kinase domain lasts between the exons 18 to 21, and exon 19 and exon 21 are the most important sites of mutation. These are the canonical or the common EGFR mutations that we are talking about. EGFR deletion 19 and the L858 are on exon 21 are the two most important common EGFR mutations. Our use of osimertinib in the frontline mainly concerns these two mutations. This presentation will not be concerning the less common EGFR mutations. Next slide, please. We can see that the EGFR mutations can be, as we know, that internationally mandated guidelines tell us that EGFR mutation should be considered from early stages, starting from stage 1B up till the metastatic stage. And here we can see in Asian population that we have a very high level of EGFR mutation prevalence as compared to USA and Europe. And this prevalence is similar across all these stages. We can see that it is lasting between somewhere between 30 to 55% starting from stage 1 to stage 4. And this is much higher than the prevalence of this mutation seen in USA or Europe. And the benefit will be similar, whether it is in the early stages or in the advanced stages. So this testing should be encouraged in all these stages. Next. So as we know, this is the 2024, though I do apologize, there have been there are further versions of modification of this guideline, but every version of NCCN in the later stage encourages all the practitioners to go for EGFR mutation testing, starting from stage 1B to 3AB in the stages being treated with a curative intent, and it is definitely mandatory for all the patients who are treated in a palliative intent in the metastatic setting. Next slide, please. So how exactly does this EGFR work? As we can see in the diagram on the left side, that when the EGFR is in the wild type, this pathway will work only when the growth factor or the EGF is bound to its binding site, and the downstream pathway is active only on binding. When the EGF and the EGFR binding site are free of each other, this pathway is not activated. But when we come to the diagram on the right side, we can note that irrespective of the EGF binding to the EGFR, whether it be the L858R mutation of the exon 21, whether it be a deletion of the exon 19, these downstream pathways are activated despite the EGF not being bound to the EGFR. The pathway is active irrespective of whether the actual EGF is bound to the EGFR or not. And this is translating into transcription, protein synthesis, proliferation, and increased cell survival, which is contributing to the carcinogenesis. Next slide, please. So coming to a short revision of the current biomarker testing and the treatment options, I will not be discussing this slide in detail. So we do know, it has already been discussed by our esteemed previous speaker, that for the first line molecular markers, for non-squamous cell NSCLCs, we should go for ALK, ROS, EGFR testing. We should definitely consider for PD-L1 testing. In the squamous cell carcinomas, also, as we have already discussed, in young non or light smokers, we should consider for a broad-based panel of mutation testing as well. This testing can be a standalone testing, or of course, NGS is encouraged in all these stages. But in interest of a shorter turnaround time, where EGFR, ALK, and ROS treatment being readily available, we can go for standalone testing for these markers and consider for a broad-based NGS the report which can follow after the initiation of the treatment. Next slide, please. So how does osimertinib work? Osimertinib is a third generation, irreversible, CNS penetrating EGFR, which is selective for the mutant stage. And it is also having activity in the T790M resistant mutation stage. So it causes inhibition of the EGFR mutant stage with a selectivity for the exon 19 deletion L858R. It has got activity against the T790M. And also it has got low activity against the wild type EGFR, which leads to a much better side effect profile as compared to the first and second generation EGFR TKIs. And to top it all, it crosses the intact blood-brain barrier. As we know that in metastatic NSCLCs, around 40% of these patients can have asymptomatic brain mets, and precluding a treatment for this brain mets, the earlier generations of EGFR TKIs did not show very good CNS activity. But in the face of a good CNS barrier penetration, we can exclude the radiation and actually expect CNS as well as extracranial activity in osimertinib, making this one of the most important weapons in the frontline treatment of EGFR mutant NSCLCs. Next slide, please. So what brought osimertinib to the frontline was the FLORA trial. It is a randomized, double-blind phase 3 study which assessed the safety of osimertinib versus a standard of care EGFR TKIs in the frontline treatment. It included patients with locally advanced and metastatic EGFR mutant NSCLCs. We go to the study design in the next slide. The patients were randomized to receive osimertinib 80 milligram per day with EGF, and the comparator arm was the EGFR TKIs, which were the standard of care, including geftinib or erlotinib. And the patients were allowed to cross over, which is to be noted, if there was a confirmed disease progression on the standard of care EGFR TKI and a T790M mutation was proven, then post-progression, the patients were allowed to switch over to open label osimertinib. PFS was the primary endpoint, and the secondary endpoints were ORR and overall survival and the others that have been mentioned. The data cutoff was in June 2017. Next slide, please. So as we can see in the slide that the ratio of the genders, the age, race, the smoking status, CNS metastasis rates at a diagnosis, the performance status, the EGFR mutations at the randomization of the DEL19 and L858R were well balanced in both the arms. Next slide. Here we can see that there is a significant improvement of the progression-free survival. The classical value of 18.9 months versus the 10.2 months, with a very early separation of the PFS curves, starting with osimertinib separating itself, the Kaplan-Meier separating itself from the standard of care EGFR TKIs with a very impressive hazard ratio of 0.46 that reduced the progression of risk of progression of or death by 54% as compared to the standard of care EGFR TKIs. Next slide. This efficacy was found to be consistent irrespective of the sex, the age, the race, the smoking status, the CNS metastasis status, and most importantly, the exon 19 as well as the L858R both showed a significant PFS advantage as compared to the standard of care TKIs. As we do know, historically, Geftinib and erlotinib data has shown that the survival was not statistically significant for the L858R, but in this case, both the mutations have shown consistent PFS benefit as compared to the standard of care. Next slide, please. The duration of response of osimertinib is almost 18 months. The ORR rates were impressively better than the TKIs, with the duration of response comparing much better, that is around 18 months versus 8 months in the conventional standard of care EGFR TKIs group. Next slide, please. Classically, we do understand that the patients who have been enrolled into a trial where crossover is allowed, the overall survival value is usually not statistically significant, which is usually owing to the crossover that has been allowed. This is one trial where the final analysis of OS, it actually demonstrated a clinically meaningful, statistically significant OS advantage of around 6 to 7 months. Osimertinib arm had an OS of 38.6 months versus the EGFR TKI comparator arm having an OS of 31.8 months with a statistically significant hazard ratio of 0.799. Next slide, please. As we have already discussed that osimertinib has a very good selectivity for the EGFR mutant form or the T790M form and shows selectivity for these mutations and spares the EGFR wild type receptors. And this translates into a much better side effect profile in terms of lower incidences of rashes and acne and paronychia, stomatitis, and a much better profile in terms of hepatotoxicity as well. Next slide, please. Here, as we can, I would like to draw your attention to the CTCAE grade 3 or more adverse events, which is significantly better in the osimertinib arm. In both any cause versus causally related to the drug itself, it is 33 versus 44% and 17 versus 28%, which favors the use of osimertinib versus conventional EGFR TKIs. Next slide. So what did FLORA teach us? It showed us that osimertinib had a highly statistically significant, clinically meaningful improvement of the PFS of 18.9 months, hazard ratio of 0.46, consistent benefit across predefined subgroups, including those with or without CNS metastasis, and a significantly longer duration of response of 17 versus 8 months. There was a much better clinical, which is a very important aspect, that the CNS PFS was much better than the conventional EGFR TKIs because of the CNS penetration of osimertinib in the preclinical that was already noted in the preclinical models. And final OS also showed a promising survival trend that was favoring osimertinib versus the standard of care EGFR TKIs despite crossover being allowed, and a much better safety profile. And this led osimertinib to become the standard of care for first-line therapy in EGFR mutant advanced NSCLC. Next slide, please. The CNS efficacy for osimertinib is an important aspect because the frequency of CNS metastasis in the patients of metastatic NSCLC who are EGFR mutant is actually much higher than those who are EGFR wild. This is true for initial diagnosis and final follow-up, where it is an astounding of 44% versus 22%, with a very high incidence of leptomeningeal disease of 9.4 versus just 1.7%. Next slide. So osimertinib shows meaningful CNS activity and this is equivalent in the patients with CNS metastasis as well as those without CNS metastasis. Despite CNS metastasis being present, the PFS hazard ratio is being maintained in this group with a hazard ratio of 0.47. And this benefit being consistent leads to osimertinib being a very important tool in the diagnosis of frontline metastatic NSCLC who have brain mets at presentation. The CNS progression events in the osimertinib group was 6%, whereas in standard EGFR TKI it was actually 15%, which is more than double. Next slide. Again, reiterating the same, that osimertinib versus standard of care EGFR TKIs, CNS PFS is significantly, statistically significant with a hazard ratio of 0.48. This is the CNS analysis of the entire data set. Next slide, please. Comparing osimertinib with decomitinib. Next slide. So decomitinib would have been the second generation EGFR TKI, which was its a competitor when it was being introduced. We have erlotinib and geftinib being in the comparator arm for the FLORA. But what happens to the second generation EGFR TKIs and why are they not preferred? This is to give a disclaimer here that this is a cross-trial comparison and should not be taken totally at face value. But for that matter, as we can see that when decomitinib compared with geftinib in the Archer, the PFS curves separate at around 6 months, whereas in the FLORA, osimertinib versus geftinib or erlotinib, the separation of the PFS curves is very early, right? From the first month itself, the benefit starts to be obvious. Needless to say, the hazard ratio is much more favoring the osimertinib, but we should understand here that the comparator arms are different and direct cross-trial comparisons are not doing justice to it. But this is to just give a rough idea of why osimertinib is more favorable. Next. Next. In view of the statistical hierarchical testing rules, the Archer trial could not statistically justify its OS advantage or its ORR. But this we did not have this limitation for the FLORA study. And the statistically significant OS difference of 38 versus 31 months with a hazard ratio of 0.79 was eventually established. Next, please. Next, please. Comparing osimertinib to afatinib. Next. So Lux Lung 7 compared afatinib to geftinib and proved a statistically significant PFS advantage. But there was insufficient events to determine OS of afatinib at the time of analysis. Osimertinib here has a median PFS of 18.9 months, whereas the afatinib arm of the Lux Lung 7 had a median PFS of 11 months. But then again, this is a cross-trial comparison. Next, please. The co-primary endpoint here, again, OS survival of OS of afatinib versus geftinib is also 27.9 versus 24.5 months, which is inferior to that was established by osimertinib in the FLORA trial. Next. Next, please. So safety profile, as we have already discussed in our previous trials when we were discussing the FLORA in details, here it stands at the same that FLORA shows rash, paronychia, diarrhea, stomatitis rates around 1 to 2%, whereas we can see that afatinib and decomitinib, which are second generation EGFR TKIs, they also have a significantly higher rate of mucositis, paronychia, diarrhea, stomatitis. This is probably, again, their selectivity for the EGFR mutant versus the EGFR wild is better than the first generations, but still osimertinib proves to be superior. Next. The FLORA study was also a study that set up a sequence Because the comparator arm, the sequencing was usually first generation TKI followed by a third generation TKI in the crossover arm. And osimertinib in the treatment arm was obviously in the front line. And hence, as we have already seen the astoundingly good results of the FLORA trial, we can safely assume that first line use of osimertinib is much better as than using osimertinib in the second line. So the dilemma of sequencing, whether to start with the first generation and then switch over to osimertinib or use osimertinib in the front line, is solved by the FLORA study. Next slide, please. So as we can see that this has been well illustrated in this diagram, that assuming that around 10 patients of EGFR mutant NSCLC start upon first or second generation TKI, when they do progress, around 30% of these patients are not fit to receive any further treatment. Either they die during first line therapy or they receive only palliation care upon progression. And in these situations, no T790M is done in the real world. Only 70% of these patients will end up receiving any form of second line therapy. So a good fraction of 30% will not receive any second line therapy at all, be it osimertinib or be it chemotherapy. And it is not possible for us at this stage to predict which patient will develop a T790M post the first line or the second generation EGFR TKI and who will not develop this T790M resistant. Next. So this makes it of prime importance that we give our patient the advantage of starting with the safest and the best drug when they are in the best performance status, which is when they are first diagnosed upfront, and not wait to give a drug like osimertinib at a later stage when they will possibly not be fit for any further T790M testing, or they will possibly not have the survival enough. They will possibly die during the frontline treatment. Next, please. So this is to show a data set as to what happened in the comparator arm and how were they predisposed. Here we can see, even in the real world, that 30% of the patients in the comparator arm, it is consistent with the data from the real world, that around 30% of the patients in the comparator arm did not receive a second line therapy, consistent with the attrition rates that are seen in the real world studies. And of these 65% patients who did receive any treatment, 47% of the patients are the patients who did receive any second line therapy. In the form of second line therapy, they received osimertinib. And this is consistent with the expected rate of T790M in the real world. But it is tragic to note that if first line TKIs are first generation or second generation, 30% patients will actually possibly not remain eligible for a second line therapy at all. Next, please. So this graph reiterates what we have already discussed, that it is only around 30% to 36% in various studies across Singapore, USA, Japan, Germany. These figures remain more or less similar across the world, that around 1/3 of the patients in clinical practice actually receive second-line osimertinib. The rest of the patients have either not undergone the T790M testing or have turned out to be negative or have received chemotherapy-based treatment. 30% of these patients who received first generation or second generation TKI were not fit for any further therapy, or there was attrition as seen in the various studies. Next. So osimertinib is our preferred a category 1 evidence from NCCN even now in 2024 for the EGFR mutant metastatic locally advanced unresectable or metastatic EGFR mutant NSCLC with an exon 19 deletion or L858R mutation in the exon 21. And how did we come to this data? How have we reached this conclusion? This is something that we have discussed in details in this presentation. Next. So to conclude my presentation, in the evolution of EGFR TKIs, it was for the first time that osimertinib, a drug came to us in the form of osimertinib that translated into a statistically significant PFS and also a statistically significant OS in both exon 19 deletion and L858R mutation of the exon 21. Median PFS that we can expect is around 8.9 months with a median OS of 38.6 months, which is significantly higher than the first and second generation EGFR TKI. Its activity is stupendous even in the patients who have upfront CNS metastasis, with much lesser CNS progression events noted in the osimertinib arm as compared to the standard of care first generation EGFR TKIs. A much better adverse effect event profile in the osimertinib as compared to the first generation and second generation EGFR TKIs, which has been discussed as a part of FLORA study, and also a comparison of the Lux lung and the Archer studies. And osimertinib hence became the new standard of care for the first line therapy in the patients with EGFR mutant advanced NSCLC. Thank you for a patient hearing.
So thank you, Dr. Dharmishta. It was a wonderful talk, and you have covered the main landmark trial, FLORA, and role of third generation TKI in these patients. So as you have clearly stated, that if we go for sequence therapy, like we start with first or second generation TKI and then go for third generation TKI, if patient progress on first and second generation TKI, then many times it is not possible to give those patients benefit of third generation TKI, because with the non-availability of the biopsy sample, or patient is not willing for the sample, or maybe if we do, every patient will not show T790M mutation, and some patients PS doesn't allow us to give next line treatment. So still a big way to go. Many times in our clinics, we have seen that even on patient, if patient shows response to osimertinib, they maybe they during their treatment duration, they progress. So there are many resistance mechanisms for the these third generation TKI. So we should do NGS again, and we should try to check what is the resistance mechanism, whether it is MET mutation, whether it is another driver mutation. So accordingly, we should treat those patients. But first of all, this is standard of care that we should start with third generation TKI. At present, this is the dictum. And in very symptomatic high burden disease, although clear-cut data is not available, most of the time it is with first or second generation TKI. But if symptomatic patient in the upfront, we can start combination with chemo and osimertinib, and we can continue then maintenance of osimertinib later on after stopping chemo when patient disease burdens somewhat decrease. So with this, thank you once again, and we will move over to the next session, and next session will be taken by me, and slides will be presented by the Nishant. So Nishant, please share my slides. So this is the last topic of the today's CME, and I'm going to discuss about reinventing adjuvant therapy in EGFR mutation early lung cancer. So we have clearly seen, as my dear colleague have shown, that there is clear-cut role of third generation TKI in the advanced and metastatic setting. Obviously, then thought process comes. So because we have seen many early stage lung cancer patients, even after adjuvant chemo, they progress or they recur, especially if early stage was stage 3 and stage 2B. So how we can decrease this progression? So then hypothesis generated by the investigators that why not we give this drug upfront in the adjuvant setting, as we usually do with every other cancer. So, and it has been shown in this landmark study, which I'm going to discuss, that if in a EGFR mutated patient, which we can check even in the non-metastatic setting, and if we give this drug in adjuvant setting, then these patients may survive longer, and especially without recurrence and progression of the disease. So this already have been shown in the previous slides, that NSCLC is one of the most common malignancy incidence and mortality wise, and there is high unmet need and high there should be further strengthening of the management plans to improve the survival of these patients. So this, I talk about this slide, so I have already talked that global 5-year overall survival rates in patients with even with resectable NSCLC. So we have done either any CTR or any CTRT and followed by resection or upfront resection, after that adjuvant chemo, all those in the early stage lung cancer. But still, up to 65 to 75% patient in stage 1B, it's 50 to 70% patient in stage 2, and 30 to 45% patient in stage 3A. This is the only overall survival rate. So rest of the patients usually recur. So approximately 80% of all cancer diagnosis is the NSCLC. Estimated 30% of the patient present with the resectable disease, but still, overall survival is not very good, and in stage 3A, it is not up to the mark. So obviously there is space, there is a big lacuna where we can act to improve these 5-year survival rates. Next slide, please. So obviously, maybe few years back, it was not a dictum, but nowadays it is recommended by various guidelines, either NCCN, ESMO, or ECMO, ESCO. So even in early stage resectable lung cancer patients, non-metastatic lung cancer patients, we should do at least EGFR testing and PD-L1 testing. So EGFR mutation, if there is a positive mutation, and if so in that case, adjuvant treatment in the form of EGFR TKI, third generation TKI is recommended. If EGFR mutation is not there, PD-L1 also is PD-L1 is positive. So in that case, we can go for adjuvant pembro, and otherwise, if both are negative, then we may follow those patients. Next slide, please. So prevalence of EGFR mutation in patient with resected and stage 1 to 3 non-squamous NSCLC. And this is the result from early EGFR study, which have been presented in ASCO in 2023. In this study, which have enrolled consecutively patient with surgically resectable pathological stage 1A, 2, 3B, non-squamous NSCLC between March 21 to October 2022 at 33 centers across Middle East and Africa, Latin America, and Asia. So overall prevalence of EGFR mutation out of these 594 patients have been seen in the tune of 51%, and out of all, del19 mutation was the most common, and second most common mutation was L858R. Next slide, please. So prevalence of EGFR mutation in patient with resected stage 1 to 3, if we see, so more than 2/3 of these patients underwent only surgical resection, and patient with stage 2 or 3 NSCLC, only 46% patient receive adjuvant systemic therapy. So obviously, standard is to give some form of adjuvant treatment, either in the form of CTRT or chemo. But many centers, many patients around the world, they don't receive any adjuvant treatment. That may be because of the patient PS, or that may be because of the patient preference. Next slide, please. So after initial treatment, more than half the patient with resectable NSCLC, they experience recurrence within 5 years. So if we can see here that one half the patient recur after curative intent surgery. So obviously this is not acceptable. This should not be acceptable, and we should improve our neoadjuvant or adjuvant strategies, treatment options to improve this outcome. Next slide, please. Coming to adjuvant chemotherapy, which my dear friend in the first topic of today's CME already have shown you that this is the age-old study, Anita study, in which stage 1B, 2, 3A NSCLC patients have been given adjuvant chemotherapy. In this study, clearly have been shown that 5% improvement in the DFS and OS after 5 years have been achieved with this platinum-based adjuvant chemotherapy. Next slide. So after that, so this third generation TKI adjuvant setting is not the first trial like that. This EGFR mutation TKI have been checked, have been tried in adjuvant or neoadjuvant setting in various other trials. But all those studies have not become landmark studies, and have not were not practice-changing study because of the mixed results. So these studies are SELECT, RADIANT, EVAN, adjuvant CTON G1104 and BR19. Because of like in some studies, like in SELECT study, 2-year DFS of 88 versus 76% have been achieved with erlotinib after adjuvant chemotherapy. And in RADIANT study, clinically meaningful DFS improvement have been achieved. But in BR19, there is no DFS or OS benefit have been achieved. So because of these mixed results, and because of the toxicity concerns, Because first generation TKI, we all know that have been associated with significant toxicity in the form of mucositis and diarrhea and thrombocytopenia and skin rashes, skin side effects. So because of those, this was not these studies results have not been taken very enthusiastically, and these were not practice changing till the recent study. Next slide, please. So what is the current evidence with EGFR TKI? If we see all these randomized trial in adjuvant EGFR mutation and SLC patients, so they may improve DFS, but there is no OS benefit with those last slide, which I've discussed in the last slide. So meta-analysis of 6 randomized trials, overall 1860 patients were taken, out of which 599 patients were with EGFR mutation. So DFS improvement is there, but OS improvement have not been seen in these studies and in this meta-analysis. Next slide, please. So why? Because I'm saying that now evidence is there that we can use EGFR TKI as a adjuvant setting. So why have these data not resulted in changing the clinical practice? And main point is no OS benefit have been demonstrated till date with these first generation EGFR TKI. Next slide. But recently, in ASCO 2023, this study, ADORA trial, have been presented, in which patients with completely resected stage 1B, 2, 2, and 2, 3A NSCLC patient with or without adjuvant chemotherapy have been recruited. So, and inclusion criteria is that these patients should have at least either exon del19 mutation or L858R mutation, which both of these mutations are most common now. So then these patients were stratified according to stage, according to EGFR mutation, whether it is del19 or L858R, and according to race. And after randomization in 1:1 ratio, these 652 patients were randomized in the trial arm in the form of osimertinib 80 mg once a day versus placebo. And then planned treatment duration was for 3 years, and treatment continued until the disease recurrence, treatment completion or discontinuation criteria met. And so primary endpoint was DFS, and key secondary endpoint was DFS in overall population, landmark DFS rate, OS, safety, health-related quality of life. Next slide. So if we see in these Kaplan-Meier plot, so in both the stages, if we take stage 2 to 3A versus overall population, both the lines are well distant to each other. This difference is from the very beginning till the very late. There is no crossing over, and clearly stated that osimertinib, if we use in the adjuvant setting in EGFR mutated early lung cancer patients after resection, so there is clear-cut benefit in the DFS. And p-value is statistically significant. Hazard ratio is 0.23 and 0.27 if we talk about stage 2 to 3 or overall population. Next slide. So adjuvant osimertinib has significantly improved CNS DFS also. So this is in the tune of, as we have seen in the FLORA study. There also it has been shown that even CNS recurrence and progression have reduced with the osimertinib. Here also in the with the adjuvant osimertinib, CNS recurrences are less because CNS mets are a poor prognostic factor among patients with NSCLC, and it has been shown with the osimertinib that improved CNS efficacy is there. So in ADORA study also, CNS DFS analysis, if we see, is better with the osimertinib use. Next slide. And regarding safety analysis, there is no new adverse event which have been noted in this study. There is no new red flag, no safety signal. As we all know that osimertinib is toxicity why it is better tolerated if you compare with the first generation TKI because of the reversible and selective T790M mutation action. And so it is not generalized action on various EGFR. So because of that, less skin reactions, skin rashes, less thrombocytopenia and mucositis with osimertinib. So here also in this study also, these side effects are as we have seen in the previous studies, no new safety signal. Next slide. So in order to improve survival, we need to put more effort to identify lung cancer early. Obviously, this is the first point. But what if we identify in the first in the initial setting, in the initial stage, And even after that, patient recur, more than 50% patient recur. So obviously that is not worthwhile. So never miss an opportunity to test for actionable mutation. And this applies to early lung cancer also. And we should collaborate with multidisciplinary team, which is a key point to improve survival and to manage whether uh, just direct surgery or in the third stage, mainly in the third stage, whether we should go for neoadjuvant CTRT or chemo followed by surgery or definitive CTRT. All those points should be discussed in multidisciplinary tumor boards. Next slide. Patient may ask for treatment options for the best survival probability and be ready to discuss. So obviously, even if drug is not associated with very much side effect, not deteriorating quality of life, even then, if we ask any patient to take one drug for 3 years, even after surgery, so they may not be that much accept this type of treatment for a long duration. So obviously, we should discuss in detail what is the best option available for the survival according to survival probability. ADORA data gives a probability of patient to remain cancer-free along with survival benefit, and being cancer-free is goal of patient as well as his treating physician. Next slide. So with this, thank you, and house is open. If any query, you can unmute yourself, you can ask. Otherwise, you can write in the chat box. So if no further query, we may close today's session. So thank you all the faculty which have given time and their valuable inputs for this to make this today's CME successful. So we have discussed about the lung cancer in today's CME and what is the overall overview of the lung cancer, epidemiology, pathophysiology, and then molecular biology also. And later because out of all driver mutations, most common one is EGFR. So then we have discussed what is the best standard of care treatment for the EGFR mutation positive metastatic and advanced NSCLC patient, and what is the role of this third generation TKI in the adjuvant setting. So with this, we may close today's session. Thank you once again, all of you, and good night, everyone.
Thank you, everyone. Good night. Technical team, please close the meeting.